Welcome, everybody. Thanks for coming to this last forum of the year, right, Eric?
Yep.
Tonight we're going to talk about the effect on the ACA and health reform of the removal of the individual mandate. I'm Frank Matricardi, and I have the honor of having a very distinguished panel. First, let's talk about a couple of mechanical things and also raise some basic questions. We're not going to have slides tonight. We're not going to have PowerPoints. And that gets away from everyone taking screenshots and scribbling furiously. But what I want you to do is start thinking about this stuff as we talk about it. So, the individual mandate as a result of the Tax Reform Act of 2017 has been removed. But lots of questions go along with that. For example, what about association health plans? They're allowed now. What about short-term health plans? And don't ask me what they are because I don't know. You can ask the panel. And what about subsidies? The subsidies, as you know, for the exchanges were there, and they were probably the reason why a lot of people enrolled. Are they going to remain? If so, at what level? Will they be reduced? Will they be increased? They ain't going to be increased, that's for sure. No. But they might be reduced. And how will this affect premiums? Premiums will probably go up. Remember, the individual mandate deletion doesn't mean that you can't enroll in exchanges or health plans. It just means that if you choose not to, you're not taxed. And that's one of the big features of it. But there's lots of ramifications to that. So can the exchanges maintain their membership? Will they continue to grow? And then we have, and Amber is going to talk about this, what I call the peculiar case of California. And California is doing a lot of interesting stuff. So tonight, without further ado, let me give you a rundown on the panel. Our first speaker is Charles Bakke. He's CEO and president of the California Association of Health Plans. And Charles is an old colleague. He represents 49 health plans, providing coverage to over 25 million Californians. And he's been at the California Association of Health Plans for at least 11 years. And his leadership is well known and respected in the legislature and among the plans themselves. The second speaker will be Amber Kemp. And Amber is the policy maven for the California Hospital Association. And Amber, too, is an old colleague. She provides advocacy and support regarding government-funded programs and other health care coverage affecting California hospitals and health systems. She heads the CHA Community Benefit Committee, represents CHA members in various state-level advisory groups, and has an extensive background in Medi-Cal, previously worked in the director's office at the California Department of Healthcare Services, and she did the famous implementation of the Medi-Cal 1115 Bridge to Reform waiver, the big thing we always talk about here. So Amber will be our second commentator. And last, but certainly not least, is Bill Barcelona. Bill is Senior Vice President for Government Affairs at America's Physician Groups, formerly known as the California Association of Physician Groups. And they have now expanded nationally. Don Crane has taken that group across the country, and they're doing very well. Bill will talk about the reaction of the medical groups to the new tax act and associated issues with that. And Bill has been there quite a while. He was former Deputy Director for Plan Provider Relations for the Department of Managed Healthcare in Sacramento. I don't think I knew you then, did I?
You did.
Is that where I met you? Yeah, okay.
Yeah.
I must have lobbied you or something. So he was at DMHC.
I was just a lot sterner back then.
Yeah. He was a lot sterner. So Bill will talk about that. And so I'm going to wrap this up now. You'll know we don't have slides. I said it before. I don't want to take any more time to talk. And we're going to have each panelist will comment for about 5, 7, 10 minutes, and then we'll have questions. And I know you guys have a lot of questions. I want you to be thinking about this stuff. I don't want to see any cameras or anything like that.
There will be a quiz.
So it's yeah. Without further ado, I'm going to call on Charles Bakke.
Thanks, Frank.
To lead us off.
Well, you guys get 10 minutes, not 5 or 6, because it's too late for me to cut stuff out. So, sorry. As Frank mentioned, I'm the president of California Association of Health Plans. We represent all of the Knox-Keene licensed plans here in California. The Kaisers, Aetnas, Cignas, Anthems, but also LA Care, Inland Empire Health Plan, all the Medi-Cal managed care plans as well, too. I'm going to just do a little bit of background. I know for a group like this stuff is pretty rudimentary, but it kind of builds into talking about the impacts of the loss of the individual mandate. So just kind of stick with me for about 2 minutes here. First off, since the passage of the ACA, you guys know California has enrolled about 1.5 million people into Covered California. The Medi-Cal program has grown from 8.6 million people to 14 million people. And it's really important to remember those two facts, that the way the ACA changed healthcare coverage in California was really in those two places, in the individual market and in the Medi-Cal program. And for states like California that elected to take the optional expansion, this is to allow childless adults to enroll in Medi-Cal, and that's who all those millions of people are, is really an incredible thing. And you can see it by the amount of homeless people who are out there who qualify now for Medi-Cal, who didn't before. And that's something that we as plans and hospitals and providers are struggling with how to deal with that population, but it's a really important part of the ACA expansion. So when everything was done, our uninsured rate dropped, and now 93% of all Californians have coverage. So in order to talk about how the individual mandate and the short-term duration plans impact our marketplace, just a few basics about how health plans and coverage and premiums work. To establish premiums, health plans look back at their past experience for about a year to 18 to 2 years, depending on how old the book of business is. They look at who they had enrolled, who those people were, what they looked like, what their health profiles were like, how many medical services they used, what benefits were provided during that time, and all the other costs that they took in over that 18-month, 12-month period backwards. And then they roll it all up and shoot it forward a year in advance and try to predict what premiums are going to be for the next year. We can't change them once we come out with them. So it's kind of important that you get them right. So who is in that pool of people covered is really, really important. It's referred to as the risk pool. And since the sickest 20% of our population generates 80% of our healthcare costs, right, it really matters who's in your pool and whether or not that pool can pay for itself. In other words, collect enough premiums to pay for the medical services. The term adverse selection, which I'm sure you're all aware, occurs when healthy people decide to leave an expensive product that has high benefits and buy down to a lower policy that has lesser benefits, leaving behind a sicker pool in the higher cost, higher premium plan with higher benefits. That was a real problem before the ACA. A death spiral is what we call in the industry when a book of business loses all the healthy people and all you're left with is the sick. And every year as you look backward and you look forward, you just keep raising the premiums and raising the premiums and raising the premiums, and people are drop out, right? So what you're left with is a toxic risk mix and a product that basically can't survive. It cannot collect enough premiums to pay for itself. So the federal actions are actually more than just the individual mandate. In 2017, they really started sabotaging the marketplace first. They cut off funding for outreach during open enrollment on the federal exchanges. Then they shortened the open enrollment on the federal exchanges for 2018. Then they cut the advertising budget by 90% for 2018. So that was what they were able to accomplish in 2017. 2018, as Frank mentioned, we had the Association Health Plan and the short-term limited duration plans proposed rules issued by the feds, and the individual mandate was erased. So to Frank's question about what some of these things are, association health plans are when small businesses band together and buy coverage like a large employer would, right? So instead of being a large employer, UCLA buying coverage, you could have a whole bunch of little businesses band together as an association and then buy coverage that way. Short-term limited duration plans are plans that were originally intended to be a bridge when someone lost coverage but wasn't eligible for COBRA or continuation coverage and couldn't get into open enrollment. So you could buy a 1 month, 3 month, 6 month, in some cases 12-month limited duration plan. The reason the feds are using these to sabotage, or how the feds are using these to sabotage the market, is that none of the Obamacare rules apply to these. So if small businesses want to pull out of the small business risk pool and form an association, they can do so without having all the coverage benefits, without having the actuarial values. In the individual market, on the short-term plans, they may even be able to underwrite, which means that they can turn away sick people, ensuring that the risk pool for the short-term limited duration plans are only healthy people, right? So that's going to make really low premiums, which is going to be really attractive to the young and healthy individuals who don't use much health care. Why would they buy this expensive Obamacare policy when they can buy this short-term plan that's much, much cheaper? So there's a strong possibility terminology adverse selection will be caused by that, to some extent, by the use of short-term policies. Of course, the people who purchase them are very happy. They're paying lower premiums. They have more money in their pocketbook until they get sick. And then they're going to complain because they have all these out-of-pocket costs that they didn't realize they were going to have to pay, and they're going to be pretty upset about it. Kaiser Health did a tracking poll and asked people nationally who are in the individual market whether you would take this option up if it was available to you. And 12% of the public said, yeah, I'd switch over to this lower cost plan if it was available to me. So now onto the individual mandate, which is really the sort of bigger one. You know, in the ACA with guarantee issue, which means anyone can buy healthcare coverage no matter how sick they are, you have to have a countervailing balance to get healthy people into the risk pool. And that's where the mandate comes in, obviously. It's to ensure that the risk pool is healthy and it can be sustained over time. It also, you know, some would say rightly, places a responsibility on the public to go out and find insurance. I mean, if you have Medi-Cal, go sign up for Medi-Cal. If you have subsidies, you should go out and take advantage of those subsidies. If your employer offers coverage, you should take it. You shouldn't say no. And that really is the move to establish a culture of coverage in California. So what will it mean not to have the federal mandate here in California? Finally, I get to the topic I'm supposed to open with. Well, it's going to decrease coverage, and it's going to increase premiums. Without a penalty, there will be some adverse selection when the healthy drop coverage and leave the risk pool unbalanced. I think a week ago, maybe 2 weeks ago, PricewaterhouseCoopers came out with an analysis of trying to look at all of the available research that's been done on this and then applied it to California's marketplace. And they estimate that the enrollment losses in California will be between 420,000 to 1 million people will drop coverage in California. That's big numbers. Even though we're a big state, that's a lot of people foregoing coverage. That includes 350,000 from Covered California, our state-based exchange, 430,000 off exchange. These are up to numbers, by the way. It's not, you know, it's a range. And even 240, 250,000 Medi-Cal recipients, which there's a number of different reasons why, and if you guys want to ask me questions later, I can talk about that. So that's the impact on coverage. The impact on premiums is estimated to be somewhat lower than the national average. Nationally, they're looking at premium increases as high as 30% on average, but in California, because we've had such a functioning marketplace, they think in at least the next year, we're looking at up to 13%, 5 to 13% impacts just from the individual mandate. So when you take those impacts and you add to them the impact of the limited duration plans, the limited duration benefit plans, which is another 3%, medical trend at 6 to 8%, Californians are going to be seeing in the individual market probably premium increases between 7 and 22% next year. And as those rates go up, some will drop coverage because there's no penalty for them to purchase coverage. Instead of just being negative, I thought I'd focus on what California can actually do to make a difference, because we're not going to change the federal government right now. There's an election coming up, but there's still going to be log jams at the federal level, and right now an administration who wants the ACA to fail. So one of the first things we can do is unlike the feds, we can continue to market the availability of coverage in California. And Covered California is doing that. They're going to spend over $100 million in marketing and outreach this year to try and encourage people to get out there and buy coverage. Secondly, we can erect roadblocks to limited duration plans, or California could, not me. But the California policymakers, the legislature, and regulators could come up with innovative ways to basically block the use of these policies in California. That's likely to happen. We could protect our risk pool by sort of putting some controls on people who are gaming the open enrollment periods, and also third-party payers who are dumping high-risk patients, high-cost patients into the individual market to draw down higher reimbursement rates, because they're impacting the risk pool pretty negatively. That's in the process of happening. There's some bills on that in the legislature. We could enact our own reinsurance program, which the feds ended a couple years ago. Unfortunately, that'll cost about $1.3 billion. So that's not likely to happen, although it would be probably one of the more meaningful things from a premium perspective. We could enact our own individual mandate as a state. We could say, we're going to require Californians, like for auto insurance, to buy health insurance, and we're going to collect the penalty, and we're going to take that revenue and reinvest it back in our healthcare system. And we could create state-funded
Charles,
subsidies.
I heard, excuse me for interrupting,
Yeah.
I heard that was going to happen, that we were going to
Well, I'm trying.
enact the individual mandate.
I'm trying. I haven't got there yet, Frank.
Okay.
I think you heard it from me on our prep call.
I heard.
Yeah, the bill has not been introduced yet. My lobbyists are still banging their heads against walls over at the Capitol. But and you could also create subsidies. Like you could add to the federal subsidies so that as the premiums increase, there's state-funded subsidies there. The problem is, again, that's really expensive. We think as health plans that we should use any revenue we bring in from the individual mandate to pay for subsidies. And actually, California paid between $300 and $400 million in penalties in a single year to the federal government under the old individual mandate. So that's not enough to subsidize everybody, but it could make a real difference. So the good news, though, is all of those Medi-Cal folks, because the feds failed to eviscerate the Medicaid program, all of those childless adults are going to continue to get coverage in California. They're protected for now, and I think that's a great thing. And the bad news is really isolated to California's individual market, which has about 3 million people in it. But as I said, we're not entirely helpless to counteract some of these things. We can do stuff in California to keep our marketplace functioning. It just takes courage and willpower. And in an election year, that seems to be in scant supply in the legislature, who, by the way, is spending most of the time debating really unhelpful things, unfortunately for our healthcare system. Longer term for health plans, if the market is indeed going to deteriorate and you're going to see adverse selection and you're going to see a worsened risk pool, people have to make tough decisions as health insurers and health plans about what to do about that. One is to turn to providers and grind down on them and pay them less, which they love when we do that. The other is to pull out of markets, that are really bad. And that's, of course, leads to less consumer choice. It leads to more consolidation, which leads to the risk pools will be isolated with fewer and fewer plans, which really drive their numbers down even more. And so if worst case scenario, in 3 years, we're in the middle of a healthcare crisis again, where we have 3 million people uninsured who used to be insured and a dysfunctional individual market, which used to be functional. That's the unfortunate situation. So that's, I guess, ending on a negative note after trying to be a little bit inspirational. But thank you guys all for listening.
Thanks, Charles. So we'll hold questions until everyone goes. So let's hear from Amber Kemp. She has some interesting commentary on the California situation.
Thank you, Charles, for that great overview, and thank you, Frank, for inviting us here tonight. I'm going to actually pick up on a positive note. I'm going to talk about some of the efforts underway in the legislature right now to sustain the gains that we've achieved under the Affordable Care Act. As Charles mentioned, California really embraced the ACA's coverage expansion provisions. We have a commitment to a culture of coverage, and that's why we've been one of the most successful states in implementing the ACA's coverage provisions. And so folks are really committed to ensuring that we maintain those coverage gains, and there are quite a few bills in the legislature that have been introduced that would sustain those gains, that would extend coverage to additional populations that are not currently covered, that aim to make coverage more affordable, and that aim to improve access. So it's important to note that even though we have reduced our uninsurance rate from 20% to below 7%, there are still about 3 million Californians that remain uninsured. About 1.8 million of them are not eligible for any of the subsidies available through the exchanges because of their undocumented status, nor are they eligible for Medi-Cal coverage because of their undocumented status. And the remaining folks are eligible for subsidies or for Medi-Cal, but they either don't know or they just haven't enrolled in coverage. So there's about 3 million individuals that still need to be covered, and so there are a lot of efforts underway to cover those populations. So I want to talk to you about a couple of bills in the legislature right now that aim to do just that. There is a bill right now, and I'll just speak very high level. If you have any questions about the specific bills or bill numbers or authors or sponsors afterwards, feel free to ask. But there is a bill that would extend Medi-Cal coverage to undocumented young adults through age 26. And the idea here is that under the ACA, young adults were permitted to stay on their parents' insurance plans through age 26. So in terms of equity, the idea is that these young adults deserve the same equity, and therefore, if it weren't for their undocumented status, they would otherwise be eligible for Medi-Cal. And so the proposal would extend coverage to this group of young adults, and that would account for approximately a little over 100,000 young adults. There's another bill that would extend eligibility for full scope Medi-Cal coverage to undocumented immigrants who are over age 65. And again, there's another, the sponsors there are bringing up the issue of equity. These are folks that aren't eligible for coverage because of their undocumented status, and they would be eligible under this bill. Now, it's important to note that the Legislative Analyst's Office recently costed out how much it would cost to provide coverage to the entire undocumented population in California. And the estimate that they used was about $3 billion, which is a lot of money. And we know that even though there's about an $8 to $9 billion revenue surplus projected, that there's no way the governor is going to commit that large of a chunk of money to this population. So I think what folks are doing is they're trying to piecemeal. How can we cover certain populations to make some progress in moving towards universal coverage? There's another bill that would streamline Medi-Cal eligibility to uninsured children and pregnant women who enroll in the WIC program. The WIC program is the Women, Infant, and Children Nutrition Program. So the idea here is if these children and young and women are already eligible for this program because they are they are in poverty, they're living in poverty, and we know they're eligible. We know that they might be eligible for Medi-Cal because of their income eligibility level. Why not just enroll them in Medi-Cal? Why not just streamline them so that they don't have to take that extra step to enroll in coverage? There's another bill that would expand Medi-Cal coverage to low-income seniors and disabled through the Aged and Disabled Federal Poverty Level program in the Medi-Cal program. So right now, these individuals are eligible for Medi-Cal coverage up to 112% of the federal poverty level. And as you all know, under the ACA, we expanded Medi-Cal coverage up to 138%. So this bill seeks to do just that for this population. It says, wait a minute, this isn't fair. Shouldn't they be entitled to Medi-Cal coverage up to 138% of the federal poverty level as well? So again, the sponsors there are putting forth another issue of equity. And then lastly, there's a bill that would extend transitional Medi-Cal from 6 to 12 months. So states have an option to apply for a federal waiver through the Centers for Medicare and Medicaid Services that would extend the eligibility through 12 months for individuals who are on the CalWORKS program. That's California's version of the Federal Temporary Assistance for Needy Families program. And so the idea is here, if folks can stay on coverage, Medi-Cal coverage for an initial 6 months, that might be the lift that they need to achieve that financial stability as they get on their feet. So again, there's another bill that would extend coverage and it again gets to the idea of equity. In terms of affordability, there have been a number of bills that have been proposed that seek to make coverage more affordable for individuals who are purchasing coverage in the exchange. So as you know, individuals in the exchange, if they have incomes up to 400% of the federal poverty level, they're eligible for federal advanced premium tax credits. Up to 250% of the federal poverty level, they're eligible for additional cost-sharing reductions that make the cost of their care more affordable.
Right.
So even with those cost-sharing reductions and the advanced premium tax credits, folks still indicate that they are having trouble paying for care. So under this bill, it would be state-funded additional tax credits for this population on a sliding scale depending on what their income is. There's another proposal that would require Covered California in providing this financial assistance to prioritize individuals who are paying more than 8% of their income on the cost of their care. There's another bill that provides for a health insurance premium refundable tax credit. And so this really aims to get at individuals who are above 400% of the FPL who aren't eligible for any subsidies under Covered California. And so for individuals between 400 and 600% of the FPL, they would be entitled to a tax credit under the personal income tax law. The bill would also require the Legislative Analyst's Office to report on the number of individuals who actually are able to afford coverage under this proposal. It's estimated that this proposal would help an additional 371,000 Californians afford coverage. In terms of access, there's a bill that would require local Medi-Cal managed care plans to offer products through the exchange in approved service areas that have overlap with counties that have only 2 or fewer plans in their region. So in California, we've been really blessed by having a really effective insurance or Covered California marketplace, in that we don't have any bare counties. Some other states, they've had insurers pull out, they've had bare counties, risk of having only one county or one plan in the county. And in California, we have a great partnership. Covered California has a great partnership with its plans, and the plans really stepped up and said, we're not going to allow that to happen here in California. And so we have good coverage. These folks who are sponsoring this bill would like there to be more options in certain parts of the state. And so they would like to explore having Medi-Cal managed care plans offer those products in the exchange. And there's another bill that would require Covered California to undertake a feasibility analysis of a public plan option. The idea there is that by having a public plan option that would offer direct competition to other insurers in the exchange. And so through this bill, Covered California would be required to do an analysis, submit that to the legislature so we could see if that's a feasible option for California to explore. In terms of preserving the advances that we've achieved under the ACA, there is a bill in the legislature right now that would prohibit the sale of short-term limited duration plans in California. As Charles and Frank mentioned, in October of 2017, Trump issued an executive order that directed his administration to issue proposed regulations on association health plans, short-term limited duration health plans, and health reimbursement arrangements. And so these are steps that California is taking to safeguard us from some of those threats. So under this bill, SB 910, short-term limited duration plans would not be able to be offered in California. There's another bill, SB 1375, which would regulate who could participate in an association health plan, and it would require association health plans to comply with ACA consumer protections. So again, California is being a leader and saying enough at the federal level. We're going to take these steps to safeguard the gains that we've achieved under the ACA. And then lastly, there's a bill that would prohibit the California Department of Healthcare Services, our state's Medicaid agency, from applying for a waiver to require work or community engagement activities as a condition for Medi-Cal coverage. As you may know, the Trump administration signaled to states that they are willing and ready to start approving those waivers so that states could implement work requirements. Our state Medicaid director has said that's not where California is going. Many members of the legislatures have said we're not going there, and so this bill would really solidify California's commitment to not including these work requirements in the Medicaid program. Many of these policy proposals were developed in response to an initiative that took place last year, and that is the Assembly Select Committee on Healthcare Delivery Systems and Universal Coverage. They convened a series of hearings from October 2017 through February 2018 to really examine California's insurance market, to examine all of the successes that we've achieved under the ACA, to understand what we would need to do to get to universal coverage. And it's very important to note that when we talk about universal coverage, we're talking about the remaining 3 million individuals. That is a separate and distinct conversation than the single payer discussion, which folks often like to conflate the two issues, but it's a completely separate discussion. And so this initiative was really to understand, well, what steps could we take to get towards universal coverage? And if any of you are interested in that effort, University of California San Francisco released a great report that summarizes and synthesizes all of those hearings. It's a great primer on California's insurance market and the steps that we can take to make progress in California. It's important to note that all bills that have been introduced in 2018 must pass the floor of their House of Origin by this Friday. As I mentioned, with regards to the state budget, there is an $8 to $9 billion projected revenue surplus. So while many of these initiatives that I mentioned are included as bills, they're also included through the Assembly and Senate, their budget proposals as well. So it will be a discussion between leadership and the governor as to what might get included in the budget, what won't get included in the budget, and what could be possibly enacted. And I would also note that there are just a lot of other folks who are vying for some of those dollars as well. So as much as folks want to make strides in healthcare coverage and ensuring that everyone has coverage, really any and all consumer advocacy organizations, there are other issues. Folks would like that money to go towards homelessness or would like that money to go towards education and so forth. So all of the proposals with regards to the budget would have to be negotiated by the leadership and the governor by June 15th. I'll pause there, and I'm happy to answer any questions that you may have regarding any of those bills during the Q&A portion.
Thank you, Amber. That was a comprehensive tour of what's going on, and now we'll have the effect on physicians and physicians.
That was masterful, and the quality of my presentation is going to suck compared to those first two. Good evening, everybody. Thank you for having the courage to come out tonight. I know we're all broken up about the Roseanne Barr thing and that loss of that immense cultural treasure. But just to add to these comments, you know, Amber's last comment about these bills having to pass the House of Origin is really telling, because there's been so much activity in this session of the legislature in terms of point and counterpoint, but it just, for those of us who work in Sacramento on a daily basis, it just feels like we're not going to end up with anything substantive by the end of this session. You know, and you've got the Senate lobbed the SB 562 single payer bill over into the Assembly. The Assembly hates it, they don't want to move it. So now the Assembly has put together this $1 billion package that Amber summarized so well. And you know, the downside of that is that there's no money for it. There's no financing mechanisms that are identified other than just the nebulous concept of, oh, we'll just raise taxes. Well, you can't just raise taxes in California. So we're just not going anywhere. And I've done some work with the Petra Center at UC Berkeley recently, where they have updated their figures in the Berkeley Forum report. We're so close to getting universal coverage in this state. You know, at less than 3 million people in a population of 40 million people, and our current costs on a gross state product basis, it costs about $10,500 per capita in California to provide health care to each of our citizens. And so if you play it out, we could cover the remaining uninsured for under $20 billion. You know, for an example, Medi-Cal costs $105 or $107 billion right now a year. I think the whole healthcare system in California is somewhere around $600 billion a year. 400 billion. It will be 6 by the end of this decade. So, especially after the next round of contract renegotiations. So, we're close. And, you know, we're now the 5th largest world economy. We have a larger economy than the UK. You know, which, when you think about it, we should have our own national healthcare system and our own Navy and probably our own World Cup soccer team. You know, but we don't because we can't print our own money. So where do we go? And, you know, I was on a plane with a good friend of mine who runs a company of 600 engineers in Sacramento and Irvine. And I was asking him about his coverage, you know, and his coverage for a family of 4 right now costs $24,000 a year. And his cost trend is at about 7% annually. And he's trying to negotiate a 3-year contract with carriers to at least keep payments level for long enough. And then you know, he feels that at the end of that 3 years, they'll just have to negotiate a better deal with another carrier. Well, what does that mean? I mean, you know, for those of you who are MPHs, you know, you probably understand that in the managed care system, the theory behind managed care is that we're going to take care of populations and we're going to improve their health status over time. Well, you can't do that in this financing system because your employers are constantly having to shift to different provider networks and different carriers because of the underlying economics of it. Now, we have so many people covered under Medi-Cal, 1 out of 3 Californians, that actually gives us the prospect of a little bit more stability if we could figure out how to do managed care in Medi-Cal correctly. But we're not there yet. Where we do a great job in California is with Medicare, with our Medicare population. We do a really great job with our Medicare seniors because the financing system is stable, because everybody understands the system, and because they like it. There's buy-in. There's tremendous consumer support of Medicare. So where do we go? The Berkeley Healthcare Forum put out a report in 2014 that proposed a transition away from a fee-for-service-based system that was based on fragmented care delivery to an integrated health system that was based on risk-based payments to providers. They theorized that you could save $100 billion over 10 years. A lot of people signed up for that report. The legislature has not really read that report, really doesn't understand the ramifications of it, but we're not going to pass taxes. I mean, this is just Bill Barcelona talking, but I think what you're going to see in November is that people are going to repeal the gas tax, for example. If people don't see the value in being taxed, 10 cents or 13 cents a gallon to improve roads in California, are they really going to vote to extend funding for Medi-Cal coverage for the undocumented uninsured? I don't think so. So how do you fund universal health coverage in California? Well, the Berkeley Forum concept, and it's been updated recently, posits that you could pull $20 million out of the system through a shared savings mechanism to fund the coverage expansion if you continue to move toward a value-based payment model and integrated delivery systems that generate more value and lower cost. So that is a way forward, and that's the way forward that APG is promoting in Sacramento, if we could just get somebody to read the Berkeley Forum report. But there just simply aren't enough UC grads in Sacramento to make that a reality, unfortunately.
Bill, do you have an author yet?
We do not, because we can't get anybody to read the report.
Just like I can't get anyone to introduce a damn individual mandate.
Yeah.
It's a theme, right? I mean, there's an underlying, sorry to interrupt, but there's like an underlying theme here of like, you can see what needs to be done, but there's a lack of will.
Yes.
And I think that's, you know, what you know, you're running into, what we're running into, what a lot of the authors of these bills are running into is just where is the prioritization of healthcare?
Mm-hmm. It's true. I mean, I feel, you know, I've been working for APG now, where the C is silent, for 13 years. And what I've noticed in the legislature over time is that we really do have more thoughtful legislators now. A lot of them the majority of them are coming out of city government, county government. They've had budgets, they've had to pay for health care at the local level. You know, they have a lot of big hospital systems that turn out to be their largest employer in their community, and so they're more familiar with this. And they are focused, they're starting to understand a few things about healthcare. They understand that costs are a big problem, that cost escalation is a big problem. But they haven't really come up with the secret sauce yet to pull the trigger on a solution. And a lot of us were just working on a bill recently called AB 3087 by Assemblymember Ash Kalra to create a statewide commission that on its face looks very similar to Massachusetts, like the Health Policy Commission in Massachusetts, but the kicker was that it had the power to set provider rates. And it just didn't appear to be constructed in the same vein as Massachusetts or even Maryland's all-payer system, where you've got a collaborative buy-in from the provider and coverage community. Yeah, Maryland's better, but it's a much smaller, 43 hospitals, 4 million people. You know, they all speak, Marylandese, and, that's not us. We're 7 different countries in California. So we successfully killed that bill on Friday.
Yeah, because it was nothing like the Maryland model. I mean,
Right.
The Maryland model.
It wasn't collaborative at all. It dictated. But the problem doesn't go away. Healthcare costs, the Petter Center calculates that our trend in California, our total spend is about 17 and some odd % under gross state product. So we're very close to the national trend for healthcare expenditures. But we're rising at a steeper curve right now than the federal. Now that may change with more of the things that are going on in the Congress. National healthcare expenditures may rise dramatically as well. But we are controlling costs in about half of our healthcare system and not controlling costs in another half, and that's our problem. We just, we can't have a unified approach toward how we do this. So,
Yeah.
Well,
So our hospitals are providing cost-effective care. When you look at all the metrics, you can see that we're actually doing a really good job of keeping folks out of the hospitals. One of the things that we're talking about more is that really it's going to take a societal approach to address social determinants of health, right? You can't just cut rates to providers. That's not the solution. It's really going to take everyone, all stakeholders together, talking about what are the underlying costs of care. And it's, as Charles mentioned, those sickest of the sickest who are driving up the cost, who have untreated chronic conditions, the folks who continue to present in ERs where that's not the most cost-effective place to receive care. And it's really going to take an emphasis on social determinants of health and understanding that an individual's economic security, their access to education, their access to healthcare, to their social and community contacts, their neighborhood and built environment, all of that plays a role in their healthcare. And until you address that, you're not going to be able to drive down healthcare costs. And that's not on Charles, and it's not on us, and it's not on you guys. It's really everyone joining together.
I mean, we're all part of the solution. We're all part of the problem. All of us, all sectors of the medical economy in California.
But you know what, Bill? We're just going to completely hijack your presentation.
Yeah.
Okay. You go ahead and try. Yeah, you try.
I am.
Okay.
And just pull you off the stage.
Yeah. No, because just to give the audience an example of how we are all working together to fix a problem, but there are just systematic things that are in our way. Treating the mentally ill. And those with behavioral health issues. These childless adults who come into Medi-Cal are incredibly high cost. They are frequent flyers. They're living under a bridge, in a riverbed. And, we're giving them $100,000 hepatitis C drugs for them to take to get over their hepatitis C, and they're not staying on them, right? And so you've got to get these folks into housing. We can't buy housing for them, although we're messing around with some pilots and we're trying to cobble together money to do this. But we can't buy a home for the homeless. You can't buy a home for the homeless. When they show up in the emergency room, they're going to treat them, and they've got to go somewhere, right? The hospital can't keep them there. And so... Well, and there's a bill that would... But I mean, the leader of Amber's organization and I are on a coalition committee where we're talking about, well, how do you take all these different pots of money, whether it's law enforcement, the law enforcement pot of money, the local county mental health dollars, the local county hospital dollars, the health plan dollars, the assisted living homes that people can go to. When you start to put the people around the table who are treating those with mental health illnesses, it could fill this room of interest groups who all have different funding streams and all have different responsibilities and roles. And so, we're not part of the problem there. We're actually trying to solve the problem, but there's so many obstacles in our way to do it.
There is.
That it can be really frustrating.
It's
kind
true. Yeah, I mean, we are really, on paper, we really have great approaches in California to solving the problems around housing, the problems around incorporation of social determinants. But when it comes down to implementation, the fragmentation in all the funding sources still, like we've seen this with the duals demonstration over the last few years. You just can't get past that final mile because of all those technical hurdles, and particularly the incorporation of behavioral health. I mean, we can't get there. So
some exciting initiatives underway right now with the whole person care pilots and the 1115 waiver, with the health plus program under the ACA, that we haven't even seen that be actualized yet. But what it has done is it's gotten folks to work across silos and to say, okay, this is an attributed population, let's start sharing data, let's work together, let's start working with social services agencies, let's start understanding what their housing needs are. And it's really encouraged folks to have those conversations with regards to the health homes program, which hasn't even been implemented yet. That's going to focus on the highest cost 3 to 5% of Medi-Cal beneficiaries. So those folks who just continually present in the ED, and what the Department of Healthcare Services is going to do is they're going to provide the health plans the data on that population every month and say, okay, here's that population, let's focus on this high-cost population, and what set of services, of care coordination services, are you going to be providing them to ensure that they have better care. And so the health plans are willing and ready and at the table to do that, partnering with hospitals and clinics and other community-based organizations. So I think that there are some exciting initiatives underway that we haven't seen actualized, and that they are promising, and they're a step in the right direction.
I agree. I do. I mean, I just think it takes a regional approach. I mean, we're just too big to do this as a one-size-fits-all, and we need more local accountability. And I think the legislature struggles with how we implement that.
Bill, I have an example, although I don't want to cut into your time.
No, I'm good.
Right, we all are.
HealthNet, one of Charles's health plans, is doing a demonstration with Venice Family Clinic to fund a pilot in nutrition for Venice's patients, of which many are homeless, and some come in regularly. There'll be health education centered around diabetes programs, usual transportation stuff, but they are going to be paying for food. And in some cases, housing fixes like air conditioners, stuff like that, or I don't know how far they're going to go, but you could have lead-based paint removal and stuff like that, all of which contribute to the social determinants of health. And we haven't discussed money amounts yet, but they're committed to doing it. Dorothy Selesky's leading it, who's a graduate of the school. Go Bruins. So that's just one idea. Tony. Yeah.
So just to the panel, gentlemen, I'm Tony Schiff. I teach health law here. And what my question would be is, so what are, you make excellent points about the social determinants and also the inability to do population management when you have people, ebbing and flowing out of plans. That makes total sense to me. And some of us, longtime Atul Gawande readers and the hot spotters, if any of you know that article. But the question that I would ask is, what are they doing in smaller, more centralized countries such as in Europe to address these same kinds of problems in terms of population management?
Well, the European model, they spend twice as much money on social services as the United States. I mean, that's a given. They have a much broader social safety net.
Yeah, it's actually really staggering. When you look at the trade-off America has made as a nation, is that over the last 30 to 40 years, we've ratcheted down social services spending while we're increasing healthcare spending. And it's the exact opposite in a lot of those other countries. So we're just switching out dollars from one pot to another, basically. We're saying, well, we're going to cut welfare, we're going to cut rent support, we're going to cut all of these benefits, and we're going to shift the costs over to healthcare. And as plans, we see this because we get asked to cover things that aren't medical, that are really social service stuff. Yeah. And you start asking, like, wait a minute, we don't have a provider group to pay to install refrigerators in people's hotel rooms.
Oh, I do that.
Well, yeah, you would, because you're a handy guy.
Yeah.
Or you get an interest group, and presto, there's a mandate bill.
Yeah.
So that you'll work.
Yeah. Well, Charles is making a great point, because right now, our discussion right now is focused on the Trump administration's decision related to the individual mandate and not having that penalty in place and what that effect has. But there are so many other decisions that are affecting the health of individuals in our country that administration is making. with regards to how, the discourse and rhetoric regarding immigrants and the effect. I mean, Kaiser Family Foundation released a report about the chronic stress that folks have if they have immigrant families, and just hearing all of the rhetoric, and we're hearing anecdotal stories about people not going to hospital and care, not going to clinics because they're afraid of deportation. So the administration's slashing dollars related to housing and childcare services. So it's like when we're in rooms with our consumer advocate colleagues, they're worried about the implications on health care, but from other viewpoints as well, because there's so many other decisions that are being made that impact an individual's health, not just related to health care coverage.
Okay. Hi, I'm Kimberly Sinclair, and I teach health education at Glendale High School. And I was listening to, this is for everybody on the panel, I was listening to everybody talk about how California is going to pave the way and do all these glorious things. So my question is, if California goes it alone, as far as mandating the individual mandate and all the other things that you talked about, would a failure from another state that didn't participate in something like that, would it negatively impact what California is doing, or would other states follow what California is doing, and then that create a tipping point for the future down the road as far as on a federal level?
Well, I mean, I think what you've seen is a blue and red divide, about other states. The red states, a lot of them didn't do the Medicaid expansion. Right. So, when Bill talks about our healthcare costs going up, we just added like millions of people in California. But yeah, I mean, in red states, they're not going to do what we're doing. If you talk to people in New York, Massachusetts, Maryland, New Jersey, they're all having these same conversations, albeit from their own parochial viewpoint, because they all have very different healthcare systems than we do. I mean, very different. I think that there are things that we've already done that has been a leader. I mean, when our state-based exchange decided to trick the feds on the cost sharing reduction and load all of the costs into the silver tier, jack up the federal subsidies for everybody else, and then migrate everyone else out of silver tiers, they basically stole the money and ran from the feds. All the states followed us, that had state-based exchanges. So yeah, I think there is a real opportunity for leadership here, and I think that we've showed that we've done it, but there's just a lot more work to do.
And the result of that is that when you look at enrollment over the past year, we see that enrollment in the federally facilitated marketplaces has decreased, but enrollment in the state-based exchanges has actually increased. And it's because of these types of decisions that are being made, led by California. And Covered California, they're taking that and they're sharing it with the other state-based exchanges and really wanting to be a leader out there.
So to answer your question, there's two things. One is, now that we've done the national expansion, we see what's going on in all the other states, and there's a lot of cool stuff going on in other states. And one of the things that I'm really attracted to in Massachusetts is the fact that they have the Health Policy Commission, and they've established a statewide growth trend, and it ranges between like 4.1 and 4.3% of their gross state product. So they manage inflation of their healthcare spend. And they don't, so technically they say it's a cap, but really it's fairly permeable. But they manage it. They've devised a way to do a top-down survey of the entire health market. And when they have uncontrollable costs, they're gaining the ability to find out what the causes are. And they're trying to address the root causes. And it's not perfect, but it is a very strategic approach. And I guess you can do that in a state of 5 million, 6 million people. It's tough to do it in a state of 40
million. It has 100% coverage. Yeah,
99.7%. Right, yeah.
Did the ACA under Romney as governor 20 years ago. Yep. I mean, they're in a completely different place.
There's other factors. Like, for example, we are one of the more healthier states in the union. Not as healthy as Hawaii, but, not as healthy as Colorado, but pretty darn good. And so we have a lot of advantages. Okay, next part. The problem here is that we put all this money into the individual market, into the exchange. And, you know, coverage, you know, fighting to subsidize the coverage and everything, it's tremendously expensive per capita and cumbersome. And the rules that have been imposed on health plans by virtue of creating the exchange and the kind of specter of that, you know, within the general commercial model, the way we've passed all the rules and regulations over the past 10 years to do this. And it's had such an impact on the employer-sponsored, fully insured market as well, driven employers out of the market. But it's much more efficient to cover people at the group level. It is. And the health outcomes are better because it's stable. And so, I mean, but, you know, I'm sure there's a lot of reasons why. This is still in its infancy. But I mean, you have to look at this. This has been policy now for 25 years, that the creation of an individual market would be the solution, you know, to create portability and not tie people to certain jobs where they're bound there by the fact that their employer provides coverage and they don't want to lose that. We got a long way to go in the individual market before you can really decide that it is a successful model. But I do think that that's been one of the problems, is that we've invested a tremendous amount of time and effort and money in the development of the individual market in California. And honestly, we haven't really covered that many more people. I mean, when I was a regulator at DMHC back in the early 2000s, the individual market was 1 million people. And that's when we were at maybe 30 million population. Now we're at 40 million all these years later, 17 years later, 16 years later. And, you know, if you believe the numbers, they say they cover 1.4 million.
But there's an outside market that's also 1.6 million, so it's 3 million total.
The outside of, yeah, the outside.
If you take the outside market and the coverage.
Yeah, okay, so you're.
So it's triple.
Yeah, yeah.
But LA Care has 2 million, 2+ million.
In Medi-Cal, yeah.
Yeah. Yep.
Any other questions?
My name is Bruce Julian. I'm an employee benefits broker, mostly in the small group market. We used to do a lot of individual coverage, but my understanding is the individual market is their companies are losing hundreds of millions of dollars. Anthem Blue Cross pulled out, which was amazing. They used to have half of the individual market and they pulled out of the market. So I have a couple of things. One was interesting, your perception that the population is at fault, and it seems to me there's some underlying medical costs in the medical system that are cost factors. I mean, each local hospital has its own MRI machine, and they market their services as an expert in this and expert in that, which sort of tends to increase the cost to everyone. Not everybody gets paid the same amount. The physicians are used as a method to drive people to the different facilities. Prescription medicine costs seem to be not regulated. I mean, I think there are a lot of other underlying cost factors, not just because of the homeless population or whatever. I thought it was also interesting, your perception that, your observation that there's been a shift in decrease in social and increase in the medical expenses because the employers really it basically a tax on the employers and the employees, and they're have been unable to control that cost expense. They get a trend increase and they have to pay it. Where are they going to go? And everybody's got the same benefits and rates. But my question, and so those are just some of my observations, that I don't know that it's necessarily the population, but I think there's some other structural things with the way healthcare has been paid for in this country, in California. But my question really gets to a more detailed thing on this risk adjustment. My understanding is that the specific insurance companies, if they do extremely well in their management of their risk, they have to pay to the other carriers. You guys haven't touched. I think it's mostly in the small group market. Is that correct?
It's also an individual market, and small group, and it's been very disadvantageous for California.
Particularly though for the HMOs, I understand, because they don't have the claims data and so, you know, from my perspective, in the small group market, this trio ACO by the Blue Shield has been extremely effective in competing with Kaiser, which are both comprehensive and integrated medical healthcare delivery systems that seem to have good quality at a low cost. But those are going to be disadvantaged in favor of these fee-for-service PPO plans that are not they don't control costs in any way at all. And then, so I just wonder if you guys could talk to this risk adjustment, if there's any way of what the long-term impact of that's going to be, because it's going to be driving out the HMOs, which really do maintain some cost control, as opposed to the PPOs.
Yeah. So when risk adjustment was negotiated in the California legislature, there was a lot of back and forth about whether we would do a California standard or a federal standard. And it was just too political to do a California standard. So we went with the federal standard, and really the downside of having done that is that it had a huge impact on capitated delegated groups, because when the exchange was opened, health plans were, outside of Kaiser, were pretty much unable to use capitated delegated groups because you can't get the precision in encounter data reporting that you get from claims data. Even though claims data is pretty stale by the time you analyze it, it's still more accurate in the long run than encounter data. And you get penalized because a capitated population looks healthier than a fee-for-service population. So they opened up with basically a lot of fragmented PPO plans. And that's been the downside of using the federal risk adjustment standard, in my opinion. I mean, because you haven't been able to use, outside of Kaiser, a lot of integrated delivery models that are risk-based in that market. It's changing slowly, slowly. Well, it's very difficult.
I have to be careful about how I talk about risk adjustment because I have winners and losers in my membership. I will say, to echo what Bill said, though, that there are some fundamental flaws in how the ACA is applied in California because the feds don't understand our marketplace, and they still don't understand our marketplace, and they don't really care because right now, blue states like ours are not in control. So who the heck cares? In fact, let's care even less than not caring at all. And it is really, really frustrating, but this was a law that was enacted to help, and I think for the federal government who looks at the Medicare program as the model, with clawbacks and claims adjudication and looking at what was spent and then taking it away from the plans and the providers and giving it back to the feds, they have a whole reconciliation viewpoint, right, on expenditures, and they just took that and applied it into a capitated marketplace. And it's fundamentally just doesn't fit here. Yeah. Although some of my plans benefit from it, and some of them don't. Well, it's only $3 million, and the employer market is still the dominant marketplace. If you look at how coverage has shifted in California over the last 10 years, Medi-Cal is now almost as large as the employer market. Right? So those are the two monsters. Yeah. And then you get to Medicare, and then you get to Covered California. And actually, CalPERS is bigger than Covered California. Don't tell Peter Lee that. But.
Yeah. But the other thing, too, is, California was one of the leaders in terms of fully insured HMO. And really, that market is dying rapidly. I mean,
in the large group?
What's that?
I said in large group you're talking about?
Yeah, I mean, I track the DMHC numbers every quarter, and we're down to, if you factor out, Kaiser is 2/3 of the fully insured HMO market in California now. There's like 3.5 million people outside of Kaiser, and it goes down every year. And you were talking about the small group market. I remember when I was a regulator in the early 2000s, the small group market was a big deal in California. Small group market is less than 2 million people now in California. It doesn't matter. Employers moved to self-funded. I mean, there's 8.1 million lives in the self-funded market in California. That's what's driving commercial health coverage now. Well, I can't hear you, I'm sorry.
The cause is because the HMOs are going to the self-insured, or is that?
It's too expensive. It's too expensive. I mean, employers they're leaving because they can't, especially in the small group market. My wife ran an advertising firm with about 20 employees, and her cost escalation was like 20% a year to provide coverage. You can't sustain it as a small employer.
We're not seeing that now. I don't know what part of LA they're in and how long that was, but we're certainly not seeing that now. We're seeing, single-digit rate increases and really more stable market from 2014 when it took over the small group market. We're seeing much, much better rates. There's a lot of flexibility. The HMOs tend to be less expensive than the PPOs. There aren't any bronze level HMO plans that are really, with the exception of Kaiser. But I think it's a vibrant market in California. You have 6 different insurance companies for a small group, and it seems to be doing well. And
I just want to put in my 2 cents that I think that that Bill's members do a great job, and that the HMO model is not dying, Bill, and that you guys you're gonna still be there and with us. And but there are headwinds, and there are currents that are
my members. They do a great job in Medicare Advantage. They do a pretty good job in commercial, and they do a not so great job in Medi-Cal managed care, and that's the problem because now 1 out of 3 people are covered in Medi-Cal managed care, and their infrastructure is old and creaky. There's a lot of potholes in the road, and nobody's investing in infrastructure because you can't do it on Medi-Cal capitation rates.
Totally.
Yeah, that's just the way it is, and there isn't going to be any more money, All of my groups, most of my groups, 90% of my groups lose commercial HMO enrollment every year. Like 1 to 3% enrollment every year, year after year. Some groups are gaining commercial enrollment, but they're gaining senior enrollment. That's what's keeping them alive and profitable, is MA.
What's the future of ACA?
So Don and I were just talking about that yesterday morning, and we think MSSP ACOs are on life support. We think they're just like one CMS decree away from oblivion. But the interesting thing is we're talking to CMS, and CMS is really interested in our proposal for globally capitated ACOs. And we may have a demonstration by the end of the year.
That would be a disturbance in the force.
I was really hot on ACOs back when we were working on the ACA, but MA is so much simpler and so much better. And this new generation that's becoming eligible as they reach age 65 is attuned to HMO. And I just think I think we're putting a lot of effort into a Medicare Part A, Part B population that is not going to be that relevant in California in 10 more years. Yeah, I think most people are, it's it went from 10% opt-in per year, it jumped up to 51% opt-in for MA. MA is just really growing nicely in California. People love it, and it's great. I mean, why would you pay, my dad was a CareMore patient, and he needed a hernia surgery at age 83. And I talked to Leba Lessem about it, and she did some figures for me. And if he had been traditional Medicare, his out-of-pocket with the same surgeon in the same hospital would have been $2,700. But because he was MA, it was $100. Why wouldn't you do that? That's crazy.
Your members are getting paid well.
What's that?
Your members are getting paid well on MA for them?
So far, they've kept up with the cuts. There's been, MA has gone down to parity, since the ACA was enacted, but it's still very lucrative.
Let's make sure everybody else gets an opportunity to ask some questions. Are there other questions? Otherwise, we can let the gentleman continue the conversation. No, I mean, it's.
Well, I'll just comment in listening to Bill while we're waiting for someone to raise their hand. I think we all have a responsibility to provide coverage and services to people who need it. And it's unfortunate that the view of some is that, you just got to chase the highest dollar reimbursement, and that's just the best business model to do because we're all going to have to work together, plans and providers, to find ways to cut costs. And if certain actors are going to say, screw Medi-Cal, we're going to do MA, We're not going to accept Medi-Cal patients. They don't pay enough. That really doesn't help California very much, and I think it's truly unfortunate. As plans, we have to put together networks, and we're trying to get quality as best as we can and ensure that patients have good choices. And to hear that, that's just not the way providers see it, it's a little disturbing. So,
yeah. I mean, that is the attraction of the Maryland model. I mean, it's so simple to negotiate an all-payer structure.
Because you're obviously not winning in your contract negotiations, so you want the government to step in and do it for you? Is that what you're?
Well, so I went back and met with the Maryland Hospital Association back when Carmela was running it, and I mean, there's still a collaborative approach. There's still a lot of room for negotiations, and yes, it's tough. It's no easier than our current system in a lot of ways, but it is simpler, obviously, if you know what your per capita payment is across all payer lines. I mean, we have so much cross-subsidization in this market.
I get it.
It discourages people from getting.
So in other words, if you have a system that sets up a global cap and delivers it to your members, then you don't actually have to keep encounter data or keep track of your expenses. You just get a check every year. You don't have to negotiate with the plan. I get it now. It took me a while to just kind of figure that out, but now I got it. So, got it.
Is it me? I hear a violin.
Yeah.
Please let there be more questions.
From Kaiser Permanente, Prof. Schiff was my professor, although I was probably not a memorable student. I wanted to ask a, basic question. If you had mentioned that, our Medi-Cal population has grown to nearly the size of the commercial population, what do you think drove that? And then the other part of the question is, aside from fee-for-service, the people that weren't covered before, I would imagine that they went to the ER when they really needed to, and that also incurs a lot of costs. So now instead what they're doing is they're going in to see their primary, and they rushed in now that, they've had the ACA. But I don't know how that, I don't know how that's so different from going to the ER. And so what does that, so did that balance out? And so if it did balance out, then why are we seeing these increases?
Well, I think the reason for the increase in the Medi-Cal population is just income inequality in California. I mean, you've just got so many people who are living below the poverty line. And, so that's staggering. I mean, it's a third of the population. And it's very, very sobering. Now when someone comes in who's on the Medi-Cal expansion, for example, the hospitals are getting paid when they come into the ER room. Not enough.
No, not fully.
Yeah, well,
Yeah.
not enough to cover your costs.
Thank you.
That would be the right term. But there is a revenue stream, a very poor one. Prior to that, those
8 cents on the dollar.
Yeah. And prior to that, what were you getting from a homeless person who came into the emergency room from Medi-Cal?
So that's a great point to make because you had raised the issue of
Yeah.
uncompensated care. So right now, our hospitals are providing about $17 billion in uncompensated care. The PWC report took a very narrow view. It used CHCF figures, which only account for charity care and bad debt. And when we do our figures, we don't use bad debt, but we do account for charity care, which is about $1 billion annually. And then we account for Medi-Cal shortfall and Medicare shortfall. And in California, the Medi-Cal shortfall is about $8 billion, and the Medicare shortfall is about $8 billion as well. So we are actually providing about 30% more uncompensated care than we were before the ACA was enacted. So the idea that if folks lose coverage and hospitals, or other people say it on our behalf, because we're not trying that we're going to have more uncompensated care. But other folks would say, well, if folks lose coverage, you're going to have more uncompensated care. We already have that, and so it's all actually gone up under the ACA.
So wait a minute. So you'd rather?
No, we'd rather people be covered.
Oh, okay. I just want to. Okay. I was like, whoa.
No, we'd rather folks speak
Okay.
covered. That's the most, I mean, so folks are presenting in our ERs, and some of our systems, they have patient navigators there who are helping to connect those individuals to a regular source of care, because they're still coming in the ER because that's where they've accessed care. And so they're helping them find more appropriate places to seek care and helping them do that warm handoff to their primary care physician and connecting them with other social services and supports. Our hospitals are very knowledgeable and they work very closely with their homeless shelters and food banks, and they know of all of those resources in their communities because they have to do warm handoffs with their patients.
Yeah. But there was I mean, to Amber's point, there was a surge of medical care that was given because people had coverage, you know, and that is something that did happen with the ACA. You know, actuarially, you know, according to the Medi-Cal plans that I've talked to, it's leveled out a bit. There was sort of a rush at the early onset, and that's kind of slowed down the growth in medical expenses. So there was a bit of a, I can't remember what the name is for that effect. You're a professor, you might know. It's the effect of pent-up demand. Thank you. Yeah. When you have people who've been uninsured and uncovered for 10 years, 15 years, and they suddenly get coverage, you know, they're going to go seek medical services. And that did happen, and that did raise costs because more people are getting care.
It takes 2 years in a population that's managed. By year 3, they're pretty stable.
Yeah, before it stabilizes.
Should I say my name again? Hi, I'm Kimberly, and not exactly sure how to phrase this question, but I would say that you're probably preaching to the choir that we all are in agreement that healthcare is good and people should have preventative healthcare. So I'm wondering what your personal counter argument is to legislatures or just people out there, because I never understand the argument of like a red state where, no, we don't want people to have healthcare. I don't get it. So other than the cost, what is the counter argument of why? No, what is the argument for why people should not buy into any kind of health insurance, regardless of what it looks like, and you're on your own?
Oh, I got this one.
Yeah, I can do something too, but why don't you go, because I've been...
So, I mean, when you're talking about healthcare, you have to start from the fundamental question is healthcare a right, a fundamental human right, or a privilege? Yeah. And we never answered that question in the Affordable Care Act because it wasn't a single-payer model, it was a pseudo-universal coverage model. I mean, we didn't answer that question, and so, you know, half the United States thinks it should be a right, and the other half thinks it should be a privilege.
Well, and there are some deep thinkers in healthcare who came up with this deep thought. And I'll let you judge. So this is not my thought, but this is the theory that is out there. It's mostly around high deductible health plans is where it really kind of got its genesis, which is different than saying no coverage at all. But the idea was that health plans and providers get into negotiations over payment rates, and they settle up on whatever the costs are going to be for the contract, and we all move forward. And when a consumer goes into the hospital or a consumer goes into a doctor's office, they pay a $25 copay. They have no idea how much it costs. Mm-hmm. And so there is no public outcry at the cost of our healthcare system for the people in the public who have actual coverage. So the deep thinkers who thought these deep thoughts thought, well, if you shifted everyone over to plans where they are paying for most of their health care, then the average consumer would feel the pain. And they would talk to their doctors, and they would talk to their groups, and they would talk to their hospitals, and they would raise holy heck. And as consumers, they would start to make choices and go in low-cost directions instead of high-cost directions, and that, in effect, would create competition amongst enrollee choice instead of competition among plan choice, which then potentially could drive down healthcare costs if enough people did it. So that's the theory, but in a lot of ways, the ACA was a counter-revolution to that theory But if you roll back pre-ACA, that was kind of a Republican conservative viewpoint of how you empower consumers to lower healthcare costs.
Yeah, you're exactly right. I mean, you can, a little bit more granular, you know, it arose out of this Harvard health economist, Regina Hertzlinger, wrote this book, Market-Driven Healthcare, in the late 90s. And this was the genesis of this consumer-driven healthcare. And the idea is, this is how you get a hold of and restructure the healthcare market in the United States. Because of the third-party payer issue, nobody feels there's any accountability or ownership, and that's why they've determined costs were rising. So she theorized, if you put the pain on the back of the individual, the patient, they'll raise holy hell, and they'll straighten things out, you know, under an economic model. Well, good luck. I mean, it's easy to figure out how to buy the right tires on TireRack.com on their rating system. It's really hard to judge quality and affordability in the healthcare system because the data is not as clear, you know?
We've seen our clients see real cost savings in that. We had some clients that we had an MRI, $1,400, was on H, had it up there, and I said, here's the provider's record, call another one, and said, $800. You call back, the other guy, if I get it done there, will you do that MRI? He goes, come back, we'll do it.
I know.
You know, that's just the point, your point about competition driving down prices. And it's difficult for consumers to understand the quality, and I get that.
Yeah.
There are some real consumer differences.
I think we have a question here. No?
My name is Marianne Probst, and I went to school here a million years ago. And I'm not working right at the moment, but I do spend a lot of time listening to both sides of the issue. I know when I come here often, it's usually a lot of the discussion is we need more money or we need more coverage or whatever. So I appreciated all the discussion you had about the costs. And I sometimes wonder if the failure, it's not a failure really of ACA, but when it went into place, we hadn't addressed some of those fundamental issues of why healthcare costs keep going up every single year. And so now we're just throwing more people in, and the cost structure still doesn't work. And what you just said about being on an airplane with a guy who runs a company with 600 engineers, I mean, I feel for the guy, right? He's got 600 employees and their families. They're not Medi-Cal, they're not homeless, they don't have the social issues you just talked about, and their costs are still going up. And so until we can address, it seems like until we can address that for that population, the Medi-Cal population and other underserved people, we're just sort of throwing money at it. I don't even know if there's any outcome measurements on the Medi-Cal population that we've covered for the last 3 years. Has anybody said, we know more people are covered now, but do we know that their health outcomes are significantly better? I mean, did they get what they should have out of it? You know, it seems, anyway, that's my only point. It seems like
I think there's data that's emerging. Amber, you want to take that one?
Yeah, well, there is data, but we also know that they have access to mental health and substance use disorder services that they would not have otherwise had access to. So I get there are improvements that need to be made, but really coverage and having folks have access to health care and learn how to be a part of the system and use the system, and that's, I think, the step in the right direction. If they're not getting the care they need, then their chronic conditions are only getting worse, and that's costing the system. That's costing everyone, right? So if they're not covered and they're not getting the care they need, that's a step to address costs and understanding what their needs are. The newly enrolled Medi-Cal population, they have substantial mental health and substance use disorder services. And we now have innovative waiver programs to address those issues. But we couldn't have done that without the ACA. We couldn't have done that without the Medi-Cal expansion, without the kind of central health benefits, without the coverage mandates, without the subsidies, everything. In Cover California, they do offer apples-to-apples comparison for plans. So here folks are saying, individuals don't know which plan to select. Well, in Cover California, they do, because they can look and they can make apples to apples comparisons that was designed very strategically just so they can do that. They can look and they can look at the quality rating system which covered California implemented before even the federal government mandated that that be implemented. They can make those choices that they otherwise were not able to do absent the marketplace.
Yeah, I think Amber's answer is right on the money, and the only thing that I would add is that to your point though about addressing the underlying costs of healthcare, I think it's really hard to completely reform a system where you don't have a handle on how much the system costs. And when you talk about, when I was complaining about the lack of willpower and a lack of leadership from politicians, right, to make real changes, to be fair, if you're a governor of a state and you're looking at a healthcare system that the costs rise 8% every single year, why would you want to take that on? You may love people who need coverage, but I mean, the state budget can't sustain that. And we talk about expanding coverage to the undocumented, which we support, those bills as well too, because we think it's important. It's $3 billion. I mean, it's a lot of money. And when so I guess I'm a little unfair in my earlier criticism because you're right, they haven't addressed the underlying costs of coverage, and we try really hard to do it, and we make people mad.
We have a question back here.
This is Tina again, sorry. So kind of pigging back to the question or the pricing availability or the pricing transparency. I know that for more simple things, you can shop around with your physicians to ask what an MRI scan is. But for the larger things like surgeries, there was a recent NPR article that talked about how this person kept getting punted between the health plan and the hospital to figure out what price, what they were going to be charged for their hip surgery. So at what point in time are we going to have that cost transparency? And do you think that would reduce costs if we shopped smartly?
I'm gonna take a flyer on that one and say not in our lifetime.
Well, some balance billing has been banned in California, and the NPR story was a national story, and so there are some protections for consumers in California from balance billing, but it happened to my mom, right? I mean, she got balance billed for $90,000 for hospital stay once, and it turns into a terrible mess.
We have great consumer protection laws. I mean, you look at a place like Texas, and there is no balance billing protection in Texas, and so you're just at the mercy of
So the NPR story, California's taken steps to sort of address some of it. As far as pricing transparency for surgical costs, I have to punt a hammer on that one. About when that's coming.
It's something that we're working on with our members.
But they do that.
But I want to answer one more aspect of your question. I mean, if you assume that you're in a PPO fee-for-service model, then all these prices are going to matter to you because it's going to be on your back to figure it out under your deductible. And if you're in a first dollar coverage model, you don't. You got a copay. It's a lot simpler. Yeah, but they have like 50 people in that plan. Yeah. Kaiser's been doing a high deductible plan since the mid-2000s. Yep. But it's a pain for the people who are in it. They never get accurate charge information. It's just hard to navigate.
I'm trying to comment on, I heard some people say that it's medical patients getting higher, better, good quality care. And also I heard some people making negative comments about not being profitable. I would disagree with that because I manage more than 120 patients. We have one of the largest managed care group, Global Care. At least 100,000 is medical. We are very profitable. Patients have access more than they have ever had all their life. The medical patients have access to all the specialists that they would never imagine they could have. allergists wouldn't see medical before, neurosurgeons, orthopedics. Our patients have it. We have it in abundance. We have more than 100 orthopedic surgeons. We have all specialties. Our patients are very happy. They would not want to go back to anything else. Doctors are joining us, primary care doctors, specialists. They're fighting to be in our group. Hospitals are coming every day for us to be in their group. It's profitable. We are making profit. We're expanding. It's not true. If it's well managed, we have all the radiology that we can need, like all you can eat. We have rad nets. We capitated them. We capitated Quest. So that we don't need to be pinching and fighting. We're able to provide everything that you need. If you need specialist care with Children's Hospital, our children go to Children's Hospital. You need specialist care for our children, go to Miller Children in Longbridge. Those are the top pediatric hospitals, White Memorial. And if somebody's real sick, we have our patients can come in UCLA here, and they can go to Keck. So I don't know what you're talking about. Our patients is getting better care than PPOs and those private insurance. Our patients, there's nothing standard of care. Well, I want to land them.
So you're with Global Care, right?
Yeah. I want to land.
I forgot your name.
I'm Dr. Anna Quinns. I'm chairman of Global Care. I went to school here.
And your group's managed by MedPoint?
Yes.
Yeah, Kimberly, Carey,
yeah. I just want to say one more thing.
Congratulations.
Yeah. We spend all our time now fighting HIDI standards. All our doctors are in competition. The same HIDI standards that all the so-called big groups are doing. Breast exam, mammogram, colonoscopy, we are fighting to have the same high standard. And we are mostly medical doctors, the ones that used to, traditional doctors that took medical. We are profitable. We just distributed money, bonuses to all the doctors. Some got 40,000, some got 30,000. We are profitable. It's not true that it's not profitable. It's not true that the standard is not. I'm not saying this. I'm saying it's better than private insurance. That's what I'm saying. Thank you.
And I appreciate that, because I felt like I was like whiffing up here trying to defend the Medi-Cal program. So I do really appreciate that. And I think one of the things that a lot of people miss about it is when you do find the ability to capitate in Medi-Cal, working with groups and providing coverage, it really frees up the ability to spend the dollars where they need to go, and to be able to make trade-offs that managed correctly can stretch thin dollars a lot further than in a fee-for-service system. And I think, it sounds like a lot of what you're talking about is proof of that, and certainly that's why I still think there's a hope for capitation and HMOs in doing Medi-Cal, because heck, we do over 80-some-odd% of all Medi-Cal patients are now in managed care. And so whether folks like it or not, we've got to figure out how to do this. And I think that it's better than fee-for-service for some providers, unless they're just pumping volume through, to be able to have the flexibility to bring in specialists or send someone someplace that they wouldn't be able to do it because they couldn't pay if they were getting a fee-for-service rate. So thank you for your comments. I certainly appreciate that.
Yeah, if I can just add to it, so we spend a lot of time in other states at APG now, and Oregon in particular. And I don't know if you were at the APG conference a couple months ago, but we had John Kitzhaber, who's the former governor of Oregon, speak, and he devised the Oregon Coordinated Care Organization model, where they develop a regional entity that's kind of similar to what we call a restricted licensee in California, and they globally capitate them. And then they have two advisory bodies, one of providers to figure out how to divvy up the money amongst themselves, and a community body that advises on where they should be spending the money. And this model has worked out really well in Oregon, and it's kind of a very effective example of this idea that Charles raised earlier about the fragmentation of payer sources. Oregon has dramatically simplified that model down to a single global cap payment. Now, it isn't perfect, but they're making a lot of progress. And I think the advantage of that model is that the providers who have traditionally warred against each other, like the clinics and the public hospitals and the docs, constantly fighting each other over the last nickel of every dollar, for the healthcare spend, are suddenly thrown into a room and the door's locked and they have to figure out how to live together and be accountable to the state government for the spend because they're on a budget. And it works. It's driving cooperation across all the silos.
It's imposed discipline.
Yeah. But then again, they're Oregonians, you know, they march to a different drummer. So, but it's a very positive example of what can be done. And, you know, if we made it if we had a cooperative delivery system across all the different silos, you put it with a Medi-Cal managed care plan, you could be pretty effective.
Yeah, and if we got shared savings from the state that we could then share downstream to the providers, you know, that would be
Again,
better.
the fundamental difference between Medi-Cal and Medicare is the stability of the payment stream. Medicare is stable for providers, and Medi-Cal is notoriously unstable for providers, and that's really the biggest problem. You save a buck in Medi-Cal and you lose a buck.
It disappears. You get punished. Yeah.
Yeah.
Thank you, Bill, and sorry, Amber, do you have any final comment? Thanks for a great panel. It was robust, good questions. I wish we had more people here, but they missed it. Now, you'll be receiving emails from the school notifying of the next set of forums, and I'll be coming out sometime this summer, so keep a watch out for it. Thanks again for everyone who came tonight, and let's give another round of applause for our